Hello students, myself Dr. Ajith, Assistant Professor from Department of Orthodontics from Vinaya Mission Sankaracharya Dental College, Salem. So today we are going to discuss about something called Preventive Orthodontics. So moving forward, I would like to quote something from Benjamin Franklin. Yeah, an ounce of prevention is worth a pound of cure, as told by Benjamin Franklin. So prevention is always better than cure. So take a look at this. In the first picture you can notice something called a beautiful lady with a somewhat acceptable smile, but in the zoom picture you can notice something called midline dystema. So with this I would like to quote, your eyes cannot see what your brain doesn't know. So most of us fail to notice some things as a dentist and as an orthodontist in growing children, which if noticed at the earlier age and given a proper interceptive or preventive treatment, you would have avoided further or complications at the future. So that is why preventive orthodontics is always important. So your eyes should only see what your brain knows. So in order to educate you all about preventive orthodontics, I am going to take today's lecture on preventive orthodontics. So moving forward, remember the codes PICS. These are all the services offered by orthodontists in general. So preventive orthodontics, interceptive orthodontics, corrective orthodontics and surgical orthodontics. Basically the services offered by orthodontists are divided under any of these four categories: preventive, interceptive, corrective and surgery. And today we are going to discuss about preventive orthodontics. So what is preventive orthodontics? Preventive orthodontics is nothing but an action taken to preserve the integrity of what appears to be normal at a specific time. Please note down, it is a action taken to preserve the integrity of what appears to be normal at a specific time. Whereas what is interceptive orthodontics? It is a phase of the science and art of orthodontics employed to recognize and eliminate potential irregularities and malposition of the developing dentofacial complex. That means already some of the irregularities are starting to appear. If you interpret at that time, that will come under interceptive orthodontics, whereas in preventive orthodontics it is the preserve the integrity of what appears to be normal at a specific time. So these are all the contents under which I will be explaining: introduction, definition, and there are various preventive procedures that is to be discussed, and then conclusion. So moving forward, preventive orthodontics is a branch of orthodontic practice focused on educating patients and parents, monitoring the growth and development of the dentition craniofacial structure, anticipating the malocclusion with diagnostic technique, and treating patients before malocclusion occurs. So preventive options carried out mostly in the growing children around 3 to 12 years. So what is the definition? As we discussed earlier, this definition was given by Graeber in the year 1966. This is an action taken to preserve the integrity of what appears to be normal occlusion at a specific time. This definition is given by Graeber in the year 1966. So what are all the procedures that are being included in preventive orthodontics? Basically parent education, that starts even in prenatal period. Education of parents starts from prenatal period, postnatal period, and in primary dentition period, permanent dentition period, mixed dentition period, and it continues. So care is control and care of deciduous dentition and extraction of supernumerary teeth and management of ankylosed teeth, eliminating occlusal prematurities and much more. So maintenance of quadrant-wise tooth setting timetable, management of ankylosed teeth, management of abnormal frenal attachment, prevention of Milwaukee brace damage, management of deeply locked first permanent molar, and space maintainer. So these are all important headings under which we are going to discuss about the preventive orthodontics. So first, moving forward, we are going to discuss about parent education. As I had told already, prenatal counseling. So parent education starts as soon as the mother got conceptual. So it starts in the prenatal period with the proper nutrition, and you should insist about the importance of oral hygiene maintenance of a mother. So then in postnatal counseling, you should always keep an eye about the proper nursing procedures and care of the child. Preference of mother's milk over bottle milk should be insisted among the parents, and the use of physiological nipple physiological nipple which is more or less resemble the normal functional activity as in breastfeeding, whereas conventional nipple which is non-physiological and does not permit the suckling of the milk lead to various orthodontic problems in near future. That is why your parent education should be important about the use of a physiological nipple which almost resemble the normal suckling activity. So moving forward, avoid prolonged use of pacifier, because pacifiers and prolonged bottle feeding may lead to caries, early childhood caries in children. So you should educate about it, and you should be educating the parent about the teething, that is the development of teeth. During development of teeth, what are all the reactions or action that you can expect. So teething and its associated irritation has to be discussed with the parents in prior, and need for maintaining a good infant oral hygiene, and you should educate the mother and both the parents about the correct brushing technique for a child. So these are all the nipples and conventional nipples. Physiological nipples should be insisted, and parents should be educated about the proper brushing technique. So coming to caries control, the presence of proximal caries. So what it can lead to if the caries is present in a deciduous dentition, there are sequence of event that can occur. That is, if there is a caries in a particular tooth, see here in this teeth there is a mesial caries. So this may lead to the adjacent tooth movement into the decayed area, and that can lead to loss of arch length and lesser space for the successivenous teeth. Successivenous teeth is nothing but a underlying permanent teeth that is going to replace the current deciduous teeth. So there will be a chance that you will lose the arch length, and that can lead to a crowding of a underlying successivenous teeth. So caries should be detected clinically and radiographic examination followed by proper restoration to prevent the loss of arch length has to be carried out. So look at here, bite wing radiograph is the key. Bite wing radiograph can help you detect the early childhood caries, and caries if detected, as soon as detected, it should be consulted with a pediatric dentist and go for a filling to prevent the loss of arch length. Next we are proceeding to care of deciduous dentition. So deciduous dentition, as commonly quoted, your natural teeth is the best space maintainer that you can give to your patients. So proper care of deciduous dentition is must. Early loss of deciduous dentition can be prevented by topical fluoride application and pit and fissure sealants application. So that can prevent caries formation in a deciduous teeth, which indeed can act as a proper space maintainer, and it can aid or guide your successivenous teeth and permanent teeth that is going to come in near future. So care of deciduous dentition is the second important topic in your preventive orthodontics. Then care about extraction of supernumerary teeth. Supernumerary teeth and supplemental teeth are extra teeth that present in addition to the normal development of teeth. Most common in permanent dentition but can also occur in deciduous dentition. These teeth can interfere with the eruption of nearby normal teeth or deflecting the adjacent teeth or erupt in abnormal position. That means if supernumerary teeth is there for a long time, that can interfere with the eruption of adjacent teeth, or it can deflect the adjacent teeth to abnormal position. So that will lead to malocclusion. So they should be identified and extracted before to prevent the crowding or displacement of the adjacent teeth. So that is why extraction of supernumerary or supplementary teeth is important. So this is third part of your preventive orthodontics. So see the example, this is called supernumerary teeth, whereas this one is called supplemental teeth. So what is the difference? Supplemental teeth always resemble the shape of a permanent teeth. So these are shape of a teeth. So this supplementary teeth is resembling the shape of the nearby teeth, whereas supernumerary teeth doesn't have a resemblance to the adjacent teeth, but it is an extra teeth present between two normal permanent teeth. Both supernumerary and supplementary teeth, as discussed, can lead to movement or displacement of the adjacent teeth and can cause crowding. So coming to next point, that is eliminating occlusal interference. So why you have to eliminate occlusal interference? Occlusal interference has to be identified earlier, that has to be identified and treated. Why? Because it can lead to deviation in the mandibular path of closure. This is important. So mandibular path of closure can be deviated, and also it can predispose to your bruxism. Bruxism is nothing but clenching of the teeth that can be created because of occlusal prematurity. So how to detect a occlusal interference? By simple use of an articulating paper, ask the patient to bite, and wherever the premature contact are there, it will be indicated like this by a coloring. So wherever premature contact, you can see a discoloration that can be selectively grinded or removed. So selective grinding can be done on these areas to clear off your premature contact. So if it can premature contact is one of the main reason for causing your pseudo class 3, and it can also cause various small occlusion if not treated at the right time. That is why eliminating occlusal interference plays a major role in preventive orthodontics. So maintenance of tooth shedding timetable. So not more than 3 months between the shedding of deciduous and eruption of permanent teeth should be allowed. If there is more than 3 months of gap between shedding of deciduous teeth and eruption of permanent teeth, then you should suspect something wrong, and you should interrogate by taking OPG, or clinical examination should be done. So 3 months of gap or 3-month time period can be allowed between a shedding of deciduous teeth and eruption of permanent teeth. So delayed eruption of permanent teeth can be due to any of these reasons, like over retained deciduous tooth roots or unresolved deciduous root fragment that may not be visible outside because small root fragments can be present that can stop the eruption or delay the eruption of a permanent teeth, or presence of a supernumerary teeth or cyst and tumors and overhanging restorations in deciduous teeth and fibrosis of gingiva and ankylosed primary teeth. Any of these can be the reasons for your delayed eruption of permanent teeth. So that is why proper maintenance of tooth shedding timetable is important, and if you can notice more than 3 months of time period difference between shedding of deciduous teeth and eruption of permanent teeth, suspect for any of these reasons, and that should be treated as and when it is being diagnosed. So that is why maintenance of tooth shedding timetable plays a vital role in preventive orthodontics. So moving forward, we are going to discuss about management of ankylosed teeth. So what is ankylosed? Ankylosis is a condition in which the cementum of the tooth root fuses directly to the surrounding bone. So nothing but a cementum of a root fuses with the surrounding alveolar bone, and is characterized by main thing is absence of periodontal membrane in a small area or whole of the root surface. So this is important point. In an X-ray, if you fail to notice a periodontal membrane continuation, lamina dura will not be, most cases lamina dura will not be intact. So those is identification, or if you fail to notice the continuation of periodontal membrane, then you can suspect for ankylosis. They are most common in deciduous molars, and the tooth affected appears submerged or in infraocclusion. That is, infraocclusion means look at the level of the adjacent teeth, whereas ankylosed teeth look at the level of this ankylosed primary second molar. It is little bit above the occlusal plane. So this is called as infraocclusion because the root is being fused with the bone. It has not erupted to its occlusal level. This is a typical identification of a ankylosed teeth. They do not resorb and prevent the permanent teeth. What is the problem if the ankylosed teeth is left like that? They do not resorb, and it can prevent the permanent teeth from erupting or deflecting them to erupt in a abnormal position. So what to do? Extraction is usually recommended to permit the permanent tooth to erupt, and in case of absence of underlying permanent tooth, crown or composite buildup or crown are advised to maintain the vertical height. So there are two scenarios. If the adjacent permanent tooth is present in OPG, you can go for extraction of that ankylosed deciduous second molar. If that permanent tooth is not there, tooth bud is not there in X-ray, then you have to maintain this ankylosed teeth, but you have to restore it to the occlusal level by using crown, or either a crown can be placed or a composite buildup can aid to maintain the vertical height of the ankylosed teeth. So that is why importance of management of ankylosed teeth. So next we are moving to management of abnormal frenal attachment. Frenum is nothing but a muscular attachment present between in the upper between the two central incisor. You could see there is a space. This spacing is called midline diastema that has been caused due to the papilla or papillary penetrating frenal attachment. So this frenal attachment, if present for long time, can lead to separation between your two teeth, anterior teeth. This commonly called as midline diastema. So thick and fleshy maxillary labial frenum that is attached to relatively low prevents the maxillary central incisor from approximating each other, that causes the midline diastema. This kind of abnormal frenal attachment is diagnosed by a Blanch test. So look at the keyword Blanch test. Whenever you talk about abnormal frenal attachment, this Blanch test is important. So Blanch test can be used to identify your abnormal frenal attachment, or in an IOPA you can notice a thickened frenal attachment between two central incisor. So next case is abnormal frenal attachment at the lingual area. This thing is called as ankylosglossia or tongue tie. So ankylosglossia or tongue tie is the abnormal frenal attachment in the lower lingual area. Is the condition present from the lingual frenum extending towards the tip of the tongue. It limits the movement of the tongue, thereby causing the difficulty in speech and swallowing. Mostly in patients who is having ankylosglossia will have a difficulty in speech and also in swallowing. So that is why management of abnormal frenal attachment is playing an important role in preventive orthodontics. Moving forward, the most important thing we are going to discuss today is about the oral habits and abnormal oral musculature. So what is habits? And there are some abnormal habits that can exist in the children that can lead to malocclusion in near future. So you have to identify those habits and you should properly treat them, and by giving habit breaking appliance or psychological training to the children can be given to prevent them from continuing with the habit. There are various basic habits such as finger and thumb sucking habits, nail biting habits, tongue thrusting habits and lip biting habits. These habits should be identified and stopped at the early age. These abnormal habits affects the muscle function. There is a muscle balance that is exist to maintain the equilibrium. So there is something called buccinator mechanism that exists in your oral cavity. These balance between the inside muscles, that is a tongue, and the outer muscle, that is a circumoral muscles, should be maintained to maintain the position of your arch or position of your teeth. This buccinator mechanism, if disturbed, can lead to malocclusion. That is why control of habit at the earlier age is most important. So when you talk about habits, you have to discuss about the trident factors habit. So three things you have to notice mainly in any of the habit. What is the duration of the habit, and what is the frequency in which the children is doing that habit, and the intensity at which the habit is being performed. So three basic things you have to notice. So based on these you have to classify, and based on this you have to decide about the proceeding with the treatment for controlling the particular habit. So there are fourth factor which has been added to these three. So there are trident factors, that is duration, frequency and intensity. There are fourth factor in which it is added by Pinkham, which is called as direction. When you talk about tongue thrusting and thumb sucking, what direction, it also matters in what clinical future you can expect from that particular habit. That is why recording a direction also important. So duration, frequency, intensity and direction of oral habit should be recorded. So take a look at this. There is a tongue thrusting. So what is tongue thrusting? Tongue is being thrusted between your two incisors. That has led to something called as anterior open bite. This is a serious problem. This dental open bite, if it continues for longer period, can even prolong to a skeletal open bite, and which has to be treated at the later age. That is why controlling the habit at the earlier age before it can cause a clinical futures is most important part of your preventive orthodontics. So there are various habit breaking appliances that can be given to the patient or children, and there are several psychological means that to control the habit are there. So that is why identifying oral habit plays an important role in our preventive orthodontics. So moving forward, the next main concern is about the deeply locked permanent first molars. So occasionally the deciduous second molar will have a prominent distal bulge. So because see this picture, there is a distal bulge of a deciduous second molar that prevents your first permanent molar to come into the occlusion. Ideally your distal incline of the second deciduous molars guides your permanent molar, but in some cases, like it is been given in this picture, the prominent distal bulge prevents the eruption of first permanent molar. So it is important for you to interfere during this age and aid in the proper eruption of permanent first molar. So what to do if you diagnose this prominent bulge? You have to go for slicing or stripping this distal surface, so that helps in guiding the eruption of permanent molar. So slicing this distal surface helps in guiding the eruption of permanent first molar. So we all know distal incline of second molar is what guides the permanent molar. If there is a bulged, like how it has been given in this picture, you can go for a slicing of the distal surface of the second deciduous molar to help in eruption of permanent molar. So coming to next, that is important thing is Milwaukee braces. So what is Milwaukee braces? Milwaukee braces an orthopedic appliance. It is a orthopedic appliance used in correction of scoliosis. For scoliosis, that is a bending problem of your back. So if there is patient who is undergoing treatment for correction of scoliosis, there will be some appliance called Milwaukee braces which will be given by a orthopedician like this. These appliance, a problem with this appliance, why you have to know about this appliance is, these appliance take the anchorage to straighten your back by taking an anchorage from the chin area, that is your mandible. So these appliance exerts tremendous force on the mandible and the developing occlusion, leading to a retardation of your mandibular growth and possible deformities that can even lead to skeletal class 2 problem. So that is why identifying a patient with a scoliosis treatment who has been given with the orthopedic appliance called Milwaukee braces, you have to anticipate about a class 2 malocclusion because of retardation of mandibular growth. That why this Milwaukee brace is causing a retardation of mandibular growth is because it takes anchorage from the mandible. So to prevent this, occlusion should be protected using a functional appliance to guide the mandible forward, or positioner made of a soft material that can help the mandible to come forward. So Milwaukee brace identification is one of the important point in preventive orthodontics. So moving forward, the most important topic of today is space maintenance. So premature loss of primary teeth resulting in drifting of the adjacent teeth into the space. So this cause abnormal axial inclination of teeth spacing or shift in midline. Whenever the primary teeth is missing, the adjacent teeth can move into that extraction space. This is called drifting of the adjacent teeth into the space. This can cause abnormal axial inclination of the teeth spacing and shift in midline. Space maintenance is a device used to maintain the space created by the premature loss of deciduous teeth. There are various space maintenance. We'll have a look into it in a upcoming slides. So space maintenance basically are given to maintain the space that is being created because of a early loss of deciduous teeth. So what are all the classification of space maintenance? There are various classifications are given in your textbook, but I have taken this for simple understanding. So there are two basic classifications such as removable space maintenance and fixed space maintenance. Under removable, there are cost partial space maintenance, rod partial space maintenance, passive, active, functional and non-functional. Whereas under fixed space maintenance, you have banded, bonded space maintenance, and functional, non-functional, band and loop space maintenance, lingual arch space maintenance, distal shoe space maintenance, transpalatal arch and transpalatal arch. So these are basic classification of your space maintainers. So what is band and loop space maintainer? See, look at here. In this example, there is a early loss of your second deciduous molar. The tooth distal to the extraction space is banded and a loop of thick stainless steel wire is soldered to it with its mesial end touching the tooth mesial to the. It is a unilateral fixed space maintainer. So take a look at this example. When there is a deciduous teeth that has been lost, so there is a space that is being created because of extraction of a deciduous teeth. So tooth distal to the extraction space will be banded, this is called band, and there is a extension of a loop which is made up of stainless steel to the tooth which is mesial to that of the extraction side. This can be used in a case of unilateral loss of deciduous teeth. So it is unilateral fixed space maintainer. So band and loop is an example for unilateral fixed space maintainer. See, this is the example. Unilaterally you can maintain this space that can help in guiding your succedonous teeth. So next, coming to crown and loop appliance. Same appliance. If you cannot band the teeth adjacent to the extraction space, you can use a stainless steel crown abutment tooth that is made in an abutment tooth, and that can used as a space maintainer. So same example, but here you see the crown has been fixed on the adjacent teeth instead of a band, and same way there is an extension that is being created as a space maintainer. This is called crown and loop space maintainer. So moving forward, we are going to discuss about lingual arch space maintainer. So it is a bilateral lower arch fixed space maintainer. So far we have discussed about band and loop and crown and loop, which was unilateral space maintenance, whereas lower lingual arch is an example for a bilateral lower arch fixed. Look at this example. This is how your basic lingual arch space maintainer appliance looks like. So lingually there will be a stainless steel thing made and it is been attached to the band at the lingual. This is called lingual arch appliance. So in these bands are cemented on the first permanent molar, and stainless steel wire is soldered anteriorly and it should contact the lingual surface of the mandibular. So these stainless steel wire should contact the lingual surface of the mandibular incisor, and posteriorly it extends to the band and it is attached to the band placed in the first permanent molar. This is the basic design of this lingual arch space maintainer. It is indicated in multiple loss of primary molars, and this appliance helps in maintaining the arch perimeter and also prevents the lingual collapse of anterior teeth. So this can act as a space maintainer, and in case of orthodontics we use it for a anchorage purpose also. So this lingual arch appliance was introduced by Lowry in the year 1904. Even though it was introduced by Lowry, the lingual arch space maintenance made popular by Mershon and Burstone, who have been given the credit for popularizing the lingual arch. So lingual arch is introduced by Lowry in the year 1904, whereas it has been popularized by Mershon and Burstone. So moving forward, we are going to discuss about Nance palatal arch appliance, so which is also called as Nance holding arch. It is similar to the lingual arch but is being made in a upper arch. So note down, Nance palatal arch is being made in a upper arch. So it incorporates an acrylic button in the anterior region that contact the palatal tissue. So there is an acrylic button that contacts the palatal tissue. They are designed to prevent the mesial migration of maxillary molars. So this is used in a bilateral space maintenance in a upper, in a maxillary. If you want to maintain space in a maxillary arch, you can use Nance palatal arch button. In mandible, you use lingual arch space maintainers. So next, coming to transpalatal arch, it is been introduced by Goshgarian. So this transpalatal arch is commonly called as Goshgarian palatal bar. So note the difference. In Nance palatal arch, it is also made in upper arch, but there is a acrylic button in the anterior region, whereas in TPA there is no acrylic button. So transpalatal arch is appliance consists of thick stainless steel that is connected from one side of the first molar to the other side of the first molar palatal arch, or your Goshgarian palatal bar. This is done for stabilizing the maxillary first permanent molar, and it can even used to correct the molar rotation, or it can be used to molar distalization. In simple terms, this can act as a space maintainer, or even if made particularly designed, it can be used to correct molar rotation, and also it can be used to produce molar distalization. So this transpalatal arch is one of the most important appliance in case of orthodontics, and transpalatal arch can be used as an important space maintainer. So next, distal shoe space maintainer, it is given by Roche. So other name of this appliance is called as intra-alveolar appliance because it is going into the alveolar bone. It is called as intra-alveolar space maintainer or intra-alveolar appliance. The distal surface of second primary molar guides the unerupted first permanent molar. When the second primary molar is removed or being extracted prior to the eruption of first permanent molar. So look at the scenario here. Second primary molar is removed prior to the eruption of first permanent molar. As we all know, this distal surface of second primary molar is only going to guide your erupting permanent first molar, but this is missing before even eruption of the first permanent molar. Then you have to go for this intraoral appliance called distal shoe space maintainer. This provides the control for the path of eruption of the unerupted first permanent molar and prevent the undesirable mesial migration. So see here, there is it is going into the alveolar bone and the distal teeth is being banded. Look at the design. Distal shoe space maintainer placed properly to guide the unerupted first permanent molar into its position. So here the mesial tooth will be banded and the extension is towards the distal side to guide your first permanent molar. So this is distal shoe space maintainer. The mesial tooth adjacent to the extraction space will be banded and the distal extension of a wire is been done and it is extended into the alveolar bone. That is why it is called as intra-alveolar appliance. This extension guide the eruption of your first permanent molar. Conclusion. Coming to the conclusion, prevention is always better than cure. So in conclusion, I want to say that preventive orthodontics plays a crucial role in promoting oral health by addressing the potential issues early. This proactive approach not only enhances the quality of life but also contributes to long-term dental health and well-being. Thank you for watching this video. Thank you so much, students, and thank you Vinayaka Mission Research Foundation Media Room for this opportunity.